we'll move on to our next speaker, and I'd like to invite Dr. RASHMIN GANDHI. Dr. RASHMIN GANDHI is a very well-known neuro-ophthalmologist who moved from Sumita's city to my city. So, welcome, RASHMIN. And he will be giving us an update on pediatric neuro-ophthalmology, what's new.
Thank you so much. Thank you, Dr. Manju, for inviting me for this lovely program. I just wanted to have a comment. I don't know whether there is any clinical equivalence. We have been doing some study on effect of different wavelength of light on pupil and on different subsets. And what we have found is that in myopes, in the age matched, they seem to be the latency to reaction is much faster to blue light. And then the theory is that maybe blue light stimulates the retinal dopamine through IPRGC, and that's the reason why they probably are more susceptible, or they're more responsive to blue light. Is there any clinical equivalence or observation?
I don't know about that, but red light as well as blue light, both have been tried for myopia control. Of the two, violet light has not worked very well for myopia control, but red light, there is one article in ophthalmology which I mentioned, published in 2022. They have said that it does help in myopia retardation.
Oh, all right. Thank you. So my role is to talk about what's happening right now in pediatric neuro-ophthalmology. Well, the most exciting part which is going on in pediatric neuro-ophthalmology is all in genetics, which is a separate talk. So I'm going to maybe stick to something more clinical. First, let's have a little overview of what's going on in neuro-ophthalmology in general. The real change which has happened with the newer knowledge has been in the field of optic neuritis. The way we look at optic neuritis and the way we treat optic neuritis is quite different in the last 4-5 years, and we have understood more about this disease in last 4-5 years than in the previous century. The other optic neuropathies, there has been some kind of knowledge addition like LHON. We know that there is a gene therapy which is going on, and I'm sure Manju is going to talk about it. Idebenone has been used in LHON. It appears that it is safe, and maybe it has some impact on progression of the visual field defect, and in some instances even reversal of a visual field defect. AION, more and more associations of non-arthritic AION have been now discovered. We know that amiodarone does cause something which a clinical spectrum which is similar to non-arthritic AION. Sleep apnea has been associated. So these are a few things which has changed in last 1 decade or so. Raised ICP by and large is one disease where the distinction between pediatric disease and adult disease is by and large blurred. I mean, both behave quite in a similar way with a similar etiological factors. Though OCT has gained quite a bit of role, and I'm going to talk about that role of OCT in optic neuropathies and also in pediatric diseases. Cranial nerve pulses in last few years, again, there has been a shift towards ordering faster neuroimaging than what we were doing maybe a few years ago, because the chances of, if you miss a tumor in a patient who seem to be having vasculopathic risk factors, then you're probably doing more damage to the patient. The morbidity is much high. Diagnostics, role of OCT, we're going to talk about it. Therapeutics, there has been now a movement. We know that Argus 2 has been now clinically approved and is being used in the US for advanced retinal degeneration. Same company has come up with an implant, which now I think the trial has begun, which is now directly implanted into the occipital cortex. And they're hoping that it will work in a similar way, where somebody who is blind because of visual pathway disease probably gain some useful vision. So for pediatric neuro-ophthalmology, I'm going to stick to optic neuritis and some of the diagnostic challenges. Genetics, as I said, there is a separate talk. So optic neuritis, a little more than a century ago, this famous at that time neuroscientist Walter Bailey thought that optic neuritis is because of accumulation of bad spirit within the head, and he said that we can probably suggest to these patients a particular procedure which will draw the vapors out of the head and remove it from the site, and the patients would improve. And what he suggested as a procedure to draw these vapors out was to comb the hair 3 times a day for these patients. And he thought that combing the hair will bring the vapor out. Obviously, he didn't think of certain group of patients, what happens to them if they develop optic neuritis. That's not Walter Bailey, by the way. What has changed in optic neuritis, especially in pediatric age group, is we were told when we were studying neuro-ophthalmology that optic neuritis is by and large associated with multiple sclerosis. It's a self-limiting disease in more than 90% of the patients, and whether you give steroids or you don't give steroids, it does not make difference at the end of 6 to 8 weeks. But now we have discovered antibody-mediated optic neuritis. I mean, there were always a group of atypical optic neuritis, but now we know why these optic neuritis behave differently. And we know that in Indian patients, these antibody-mediated optic neuritis is actually form the majority of our patients. There are 2 antibodies which we know or are aware of and which we test regularly. That is antibody to aquaporin 4 water channels as a marker for neuromyelitis optica, and the MOG antibody. Now, why it is relevant for our session today is that in older days, we used to say that optic neuritis is a disease of young adult female. But these 2 antibodies, the NMO, can occur at any age group. It is more common in middle-aged females. But there are multiple studies which have said that between 5 to 8% of children can also have optic neuritis because of NMO. Out of optic neuritis in pediatric age group, 7 to 8% can be because of NMO. So it appears that NMO can affect even a pediatric age group. And MOG optic neuritis, in fact, one of the predominant groups which can be affected by MOG antibody is children. So that's the reason why it's important for us to know for this session as to what are the features of antibody-mediated optic neuritis. Again, a typical optic neuritis, as it was described in the literature, was more common in Caucasians, than in Africans or Asians. But NMO is much more common in our population, and MOG can affect any race. What about visual acuity index? What's the difference between a so-called typical optic neuritis and an antibody-mediated optic neuritis? The typical optic neuritis generally would have mild to moderate visual deterioration on presentation, while both NMO and MOG-mediated optic neuritis would have a severe vision loss. They also exhibit more disc edema than somebody who has a typical optic neuritis. And MOG is much likely to be bilateral on presentation than either NMO or a typical optic neuritis. What about progress and recovery? Typical optic neuritis, more than 90% of these patients would have a recovery even without intervention at the end of 4 to 6 weeks. And patients who have optic neuritis with a circulating antibodies to aquaporin 4 antibody, they generally have a poor recovery. MOG is somewhere in between. Most of the patients with MOG antibody would be more benign than NMO, and they will have a good recovery. So when do I suspect in children or in adults as to I'm dealing with antibody-mediated optic neuritis? Pain seems to be much more common. Patient complaining of pain seems to be much more common in a typical optic neuritis versus in antibody-mediated optic neuritis. Disc edema, bilateral presentation, or a severe vision loss on presentation are features of NMO or MOG. They don't respond to steroids so readily. So it might take 3-4 weeks for a patient to come back to normal. In typical optic neuritis, in these patients may not recover any visual acuity. Apart from that, these are some of the features which are fellow travelers with patient with NMO optic neuritis, that is weakness or paralysis of the legs and arms, painful spasms, loss of sensation, uncontrollable vomiting and hiccups, and that happens because NMO-mediated optic neuritis generally would have features which affects hypothalamus, and that's why vomiting or hiccups can be a persistent symptom. The treatment also differs now. We were told that even if you don't give steroids, really you are not really harming a patient in typical optic neuritis, but that has changed considerably. NMOSD in children in an acute phase, every child should receive IVMP of around 30 milligram per kilogram to up to 1 gram, and generally this steroid is given for 5 days. Children who are not responsive to this treatment, acute loss of vision may benefit. Remember, because this is an antibody-mediated problem, so if you demonstrate antibody in the blood, they may benefit with 5 to 7 cycles of plasma exchange. In fact, it is believed that early plasma exchange may prevent the occurrence of deadly neurological comorbidities like paraplegia. Children may also respond to IVIG, and that decision is something which we take in partnership with neurologist. So that's about the acute phase. What about preventive phase? What would you do in patients who have a circulating antibodies? Azathioprine seems to be a drug of choice with a lot of neurologists, and generally that's given for, in a MOG antibody, it's given at least for a year or more. And NMOSD, these drugs may have to be given for a longer period. If patient has a deterioration of problem or there is a new symptom while azathioprine is being given, then rituximab or mycophenolate are other options. There are new agents, some of it which Dr. Soumya was mentioning, like tocilizumab. They all have been tried in NMOSD, and they seem to have some role to play, though we don't have any large study to confirm it. So that's about the NMOSD treatment. One of the indicators in children or in adults about NMO would be on MRI, where generally a long segment of the optic nerve is affected. You'll find white or hyperintensities in chiasma, optic tract, which is not a feature of typical optic neuritis. You also see these areas like area postrema or dorsal midbrain getting lit up, which generally you don't see it in typical optic neuritis. A slide about MOG, which has a similar spectrum as NMO, though probably a little benign than NMO. It has more, this is much more common. MOG-associated optic neuritis is much more common in pediatric age group. They can have an associated encephalitis, more bilateral, more monophasic. They have a better recovery. And again, MRI would give you a clue. NMO generally would have a long segment getting affected, while in MOG, there would be widening. The sheath of the optic nerve also gets lit up, and so they will exhibit perineuritis on MRI scan. Why all this is relevant for us is because a lot of these diseases now, ophthalmology would be guiding or governing or will be an important member of the team which will manage NMO, because we would be knowing whether patient has a disc edema, bilateral simultaneous presentation, profound visual impairment, which are pointers towards antibody-mediated optic neuritis. So that's about the optic neuritis. There have been some developments in the way we look for pupil. RAPDX, the objective way of checking pupil, is now commercially available. I know LV Prasad Eye Institute also has a pupil measurement tool, and which is an objective tool of measurement of an efferent defect, and probably would be very useful to be used in children. OCT, of course, one would argue and say that most of the machines don't have a normative database in children, and can it have any significant role? Well, there are researchers who are using OCT to differentiate pseudopapilledema versus papilledema, or it has been used even in optic neuritis. It is suggested that optic neuritis with macular star or neuroretinitis, sometimes in children the macular star takes a little time to form, but in those patients who are going to develop neuroretinitis, they can have a bright internal limiting membrane, and you know that you are probably dealing with an infective optic neuritis which will settle with antibiotics. In case of hydrocephalus, this is something which I fished out from the literature. where patient had 2400 vision, but RNFL, the average RNFL was normal, and the child was given a diagnosis of a functional vision loss, but then ganglion cell layer was actually completely absent. So patient actually had a problem. OCT to monitor IH and also visual in young patient. It's been published. IH monitoring with OCT is an objective way to say whether the optic disc edema is going down. You have a number to it, but we have the word of caution that disc edema might be going down either because patient is responding to your treatment and really the fluid is going down, or the disc edema initially is going down because patient is actually losing neurons, and that's why the average number is down. And way to differentiate between the two, whether patient is responding to treatment or not responding, is to have average RNFL with a GCC thickness. So in a nutshell, there have been now movements in a lot of diseases in neuro-ophthalmology. Most important part is in genetics, but there have been some changes now in the way we deal with optic neuritis and the way we use OCT in these disorders. I thank you once again.
Thank you very much.
If anyone has any question for Dr. Gandhi, you can take that.
In your pediatric age group, have you encountered any case of Tulaza-Hunt syndrome?
Not me, but I don't know. Manju, Tulaza-Hunt syndrome?
The more I've seen in adults or in older teenagers, no, none less than 12 years of age.
I have seen 4 cases in adults. Basically, it's a kind of inflammatory or autoimmune stuff of the structures which pass through the superior orbital fissure and the cavernous sinus. Patient complains of hemicrania, periorbital diplopia, and on examination you have a kind of a proptosis, ophthalmoplegia, and involvement of second, third, fourth nerve, and the first and the second division of the sensory fifth is involved. The steroids are both therapeutic and diagnostic. I have seen 4 cases in adults, but I have seen in 1 case in a pediatric age group, and unfortunately, the 4 cases they recovered, but this girl didn't recover.
So these 4 were all pediatric?
No, 4 were adults.
Adults. Oh, we see a lot of adults.
Adults, yes.
But one of which case I saw was a girl where we gave her steroids, she did recover, and even the visual response was not good.
Yeah,
so I've seen 1 pediatric age group with a Tulaza-Hunt syndrome.
Interesting. Though a word of caution in some of these patients, because of the area where all this inflammatory material is affected, some of these patients can be harboring even infection, which goes through the sinuses, and that's where we have to be careful with.
MRI is mandatory, and it has to be it's different diagnosis, sarcoidosis.
Yeah.
Rashmin, I had a question for you. In a case of a, say, 10-year-old, very young child, if you're planning to give an intravenous methylprednisolone, do you give it as 1 gram per day?
No, generally it's a 30 milligram per kilogram.
So suppose they weigh about 20 kgs, 25 kgs, it becomes much higher, no?
No, 600.
Yeah, it is much lower.
600, yeah.
It is much lower.
Yeah.
So you reduce the dosage usually depending on the weight.
And generally we, most of these patients, we make sure that we do it in conjunction with a pediatrician or with a neurologist because you require monitoring.
So why I asked was the pediatrician told us you can go ahead with a 1 gram. We give it all the time for these renal patients. Yeah. Please go ahead. It is very safe.
Yeah.
So which is why I asked this question.
But a neurologist generally would prefer to say that we match it with the weight, though there have been reports saying that you can go easily with 1 gram and nothing happens. But we generally give this 30 milligram per kilogram.